Tinea barbae, when it affects the beard area, it's seen in males. So beard and mustache area, disease in male adults, and inflammatory variety can occur like seropulent and discharge papulopustules. Hair can be easily epilated. Secondary bacterial folliculitis can occur, confirmed by KOH mount, potassium hydroxide mount, that is, you have, I think, learned in microbiology. So this is Tinea barbae when it affects the mustache and the beard area. With secondary folliculitis means inflammation of the hair follicles. So along with fungal infection, secondary bacterial infections can occur. So we give both antifungal and antibacterial in these cases. So Tinea faciae, this is very commonly you can see in OPD. So you see an annular ring pattern. So the Tinea faciae is when it is sparing the beard area, like ears, other areas. When sparing the beard area, we call it Tinea faciae. Burning and itchy sensation, erythematous scaly patches, extends peripherally, raised border, central area of hypopigmented or brown, seen often in immunocompromised patients. So very common. Tinea corporis, when it affects other parts of the body except the scalp, beard, face, hands, feet and groin. So when it is affecting all other parts of the body, we call it Tinea corporis. Fungus, it enters the stratum corneum. If you have you learned skin anatomy? Skin anatomy. So stratum corneum is the most uppermost layer. So and spreads centrifugally. So this is the most common infection we see, Tinea corporis. It is polycyclic annular, border is erythematous, vesicular and scaly, central clearing with hyperpigmentation, concentric rings may be seen. It's like more circular ring type, and mainly under the waist, under the breast, abdomen, thighs, back also. So also in skin, very important that more or less many diseases look similar. So differential diagnosis is very important in skin disease. If anybody wants to go in like in dermatology, you have to know differential diagnosis. Like many skin lesions look similar but may not be that disease. It's like for acne, so people, anything papular or nodular on the face is not acne. It may be there can be other diseases also. So we have to also keep other diseases in mind, because if you don't do proper differential diagnosis, then your treatment may be wrong. Like if you confuse tinea with psoriasis, in psoriasis you will give steroids. If you think tinea, if you don't think, if there is tinea but you think of psoriasis also sometimes annular pattern is there. So if you give steroids thinking it is a psoriasis, then it will increase tinea. Okay. So Pityriasis rosea, very common viral fever you see in backs. It also almost looks like tinea on the back, but it has another pattern that you will learn more after seeing more cases. So it looks like tinea. Syphilis also is secondary syphilis. These are very eczemas, more looks like tinea but may not be tinea. Okay? So that time you have to be very like you have to rule out other diseases and give proper treatment, or else if you give steroid in tinea thinking of psoriasis, then you will increase the disease. This when it affects the palmar surface of the skin. So mostly seen in adults. So one is inflammatory variety and one is non-inflammatory variety. So mostly we see the non-inflammatory variety. Tinea pedis, when it affects the soles of the foot and the feet, more very commonly seen. We see in athletic foot, those who are joggers, football players, cricket players, we see mostly. Affects the soles of the feet, then it is Tinea pedis, mostly seen in developed countries because they always wear shoes all the time. So wearing of shoes and resultant maceration, adults, males are most affected. So this is Tinea pedis. Upper one is non-inflammatory and lower one is inflammatory variety. So also you can confuse with normal eczema. So you have to do like the first classical point is tinea affects mostly one side, one foot another foot is spread, then think of tinea. But if both feet are equally affected, then it is eczema. So tinea pedis, so how to manage that I will come later. So you have to keep it dry, avoiding closed shoes, nylon socks, use of antifungal powders. Okay. So tinea cruris is very common. So it is affecting the groin area. Itching is most complaint. Surfly demarcated erythematous advancing annular skin rash affects the groins. Scaling is variable, and sometimes there is inflammatory changes. So when it affects the nails, we call it onychomycosis or tinea unguium. So 20% of all nail disease has fungal infection on nails. So there are 4 varieties of onychomycosis. So distal, lateral, subungual, proximal, subungual. This according to the site of infection: white, superficial, and total dystrophic. So this is distal, lateral, subungual infection. You can see distally and laterally of the nail. So most common is tinea rubrum. Toenails are mostly affected. Starts with distal nail bed and lateral nail fold, and mucous proximally. Very common. Then superficial white color dots over the nail plate. Then proximal subungual, this is below the nail, fungus you can see. Mostly if you think of this, then think of HIV patient. Then I come to the treatment. So we mostly use azoles. So bifoconazole, oxyconazole, clotrimazole, miconazole, butaphen, then terbinafine. So we have in vehicle form lotions, creams, powders, gels are available. Systemic we use griseofulvin, fluconazole, terbinafine, itraconazole. Duration is mostly 4 to 6 weeks. It can be up to 8 weeks. For nails and nail, we can go up to 6 months. So treatment of onychomycosis, you see 3 to 6 months. For fingernail, it takes 3 months. For toenails, it takes 6 months. There are some nail lacquer, like nail polish type application. We call it nail lacquer. So cycloperoxylamine nail lacquer, we have 8%. Amloriphyll nail lacquer. These are some, like you cannot give cream and lotions on nails. That's we have, because it will wash up. Nail is a dead skin. So we need nail polish type. So it's called nail lacquer. So onychomycosis treatment is not on daily basis. It is like on pulse basis. This one I am not getting detail, because unless you go into the clinics, it will be very difficult to understand. So basically treatment principles, we have to counsel the patient that it may take 3 to 4 weeks, also up to 6 weeks, and treatment will take, we have to give antifungals 1 to 2 weeks beyond clinical cure. So hygiene is very important, proper clothing. Onychomycosis may require 3 to 6 months, may take additional 4 weeks beyond apparent cure. So temporary relief should not be mistaken for cure. Like many patients using up to 5 days, 10 days, they feel very satisfaction, there is no symptoms, but they stop the treatment. But what happens? Clinical cure and microbiological cure is different. Like fungus is there but not showing symptoms. So you have to give for a long time. Now we come another most common fungal infection, that is candidiasis. I think you heard of Candida albicans. So causative organism Candida albicans, topicalis, pseudotopicalis. Most common infection is mucous membrane, skin and nails. Mucous membrane, you see oral thrush, you see in babies and infants and children. Those are immunocompromised, they have oral thrush. Very commonly you will find it out. Very important, candidiasis. You see oral thrush, especially on immunocompromised patients. Then there is angular cheilitis. Both sides of the lips, you have some fissures there. So this can be fungal also. ভিটামিন ডেফিসিয়েন্সিতে এরকম হয় না। সো এটা বলে যে ভিটামিন ডেফিসিয়েন্সি, বাট সবসময় ভিটামিন ডেফিসিয়েন্সি মানে চিলাইটিস হতে পারে, বাট অ্যাঙ্গুলার চিলাইটিস মোস্টলি ফাঙ্গাল। Then vaginal infections like white discharge from vagina, mostly common is candida. So vulvovaginal thrush, itching and soreness is more of a curdy appearance. When you will do gynecology, so if you see, there will be curdy. So more the curdy, then it is creamy and curdy, then it is suspicion of Candida. So balanoposthitis, mostly glands of the penis is infected. So there is some fissuration, then there is whitening of color, like scales, not scales, like there is deposition of whitish material, especially those who are diabetic and those who are uncircumcised males are more affected. Diabetics people are mostly affected. When you see balanoposthitis, always give blood sugar test. And also when you see vulvovaginitis, then also give blood sugar test. So Candida is very common infection in genital area, and also it can be transferred sexually. Intertrigo, same, you can see when it is affecting the skin folds, you see under the breast, you see the groin area, or where there is fat, very much fat deposition is there, and skin is very much what I can say, very loose skin, flabby skin, where there is so many layers of the skin and each skin folds are getting attached. So there is moisture, and so you get Candida. Candida is commonly present in our skin, it is very common, but when our immunity goes down and humidity goes up and also the environmental factors plays a role, then it it causes diseases, so it causes inflammation. So you also seen on nails, those who are washing their hands more, using washing clothes, washing like maids and all, they have fungal infections. They are using more water regularly. So treatment is more or less same. We use mostly azole groups. Then Pityriasis versicolor. Pityriasis versicolor is also very common. Bengali we say shuli, chuli. I do not know what is in Hindi. Very common, that whitish and brownish patches you see, very common. Those who are, now this is the season of Tinea. So you see on the trunk and the chest area, very common shuli jeta hoy. So same thing, but etiological agent is Malassezia furfur. So this is not Candida. It is all are fungal infections, but their species are different. So again, common in young youth, familial genetic predisposition, multiple discrete discolored macules, sometimes can be fawn color, brown color, grey color, hypopigmented, pinhead size, large streaks of discoloration, seborrheic areas mainly behind, you see near the necks, upper half of the body, trunks, arms, neck, abdomen. So you see in KOH preparation, potassium hydroxide preparation, for any fungal infection, potassium hydroxide preparation is very important. We send to microbiology department. So these are the fungal hyphae. You can see mycelium, fragmented short filaments. So these are microbiology part. But in versicolor, we see spaghetti and meatball appearance. It is an MCQ question, spaghetti and meatball appearance. So this is an MCQ here. Okay. So treatment is again same. We use the azole group mostly.